We're looking at the manubrium, the body, and the xiphoid of the chest, the sternum. Notice that there's a cartilaginous link. The rib bones don't actually link directly into the chest. They link through cartilage. This is called the jugular notch. This is called the angle of the sternum. Manubrium, body, xiphoid, sternal angle, jugular notch. If we turn this around, if we were looking at the head of our patient, then this part of the clavicle would articulate with the manubrium. I call this the sternoclavicular joint. Anyhow, I don't really say manubrio clavicular, even though that probably is correct. This is a right scapula, and this is the acromion process, and this is the coracoid process. Here's the glenoid fossa, where the right arm is going to articulate. The distal end of the clavicle articulates with the acromion process, and it makes the acromioclavicular joint, the AC joint. When a person falls down on the point of their shoulder, it can rupture the ligamentous contact between the acromion and the clavicle, and it can also rupture ligamentous contact between this tubercle, the conoid, and the coracoid process of the scapula. And so one of the tests for an AC joint separation is to stabilize the shoulder and then push the arm down, and if there's too much inferior movement excursion, then it could indicate that there's a rupture of one or all of these ligaments. And of course this would usually probably get a pretty good grimace from the patient, and usually, I want you to film in here, usually the patient's going to already be holding their arm like this up against their side, and you won't have to guess. You won't really have to, you'll already know that they're trying to preserve this joint and keep this from further excursion. That does not feel very good. Not at all. So this is the conoid tubercle. Here's the distal end, the acromial end. Here's the sternal end of the clavicle. It's kind of an S-shaped bone, pretty easy to remember. Let's look at the scapula just for a few moments. There is the glenoid fossa, and this is where the head of the humerus would articulate. The articulation is completed by a cartilaginous lip called the glenoid labrum. One of the problems is if a person is laying on their back and they're doing bench presses, hundreds of pounds. Imagine it. You've got hundreds of pounds and there's nowhere to go except into the cartilaginous labrum. And so a lot of people that do bench presses eventually get frozen shoulder syndrome. I've seen a lot of it. You can be a great big guy and big huge muscles and really not be able to move your shoulders very well. That's kind of what happens. This is not a weight-bearing joint. It's not meant to be. On the scapula, there is the spine of the scapula, which leads out to the acromion. The coracoid is a big attachment site. I believe one of the bicep head tendons is attached here. There is the supraspinatus, infraspinatus fossa. There is the subscapular fossa. And a lot of times when people rotate their shoulders around, they'll hear this grinding of their shoulder up against their body. And there may be little muscular gristle-like connections between the scapula and the ribs in the back. This is the medial border of the scapula. This faces inward. So if we retract the scapula, we're bringing this inward with the rhomboid muscles. A lot of the muscles that control arm movement attach to the scapula. So we're talking about teres major, teres minor, subscapularis, infraspinatus, supraspinatus. So many of the ones that control the arm originate on the scapula. And so because the articular surface of the scapula does not have a deep cavity like the acetabulum of the hip, it is mostly a muscular reinforcement. So rehabilitation of the shoulder joint oftentimes involves some kind of a shoulder rehab. And when a person has a problem, they say, I have a rotator cuff problem. And that could be quite complex. I think with a rotator cuff problem, you could have a supraspinatus problem, which is one of the muscles that abducts your arm. You could have problems with some of the other muscles that rotate your arm in and out. You could also have a cartilaginous lip issue. And you could also just have fixation, trigger points in muscles. That is a complex and difficult problem to alleviate.